Welcome, and thank you for joining tonight's Ask the Experts virtual event, Everyday Back and Neck Aches, Prevention, Coping, and Managing. I'm Dr. Russell D'Amico, a spine medicine interventionalist here at Cleveland Clinic. Joining me are fellow spine and pain specialists from Cleveland Clinic. The Cleveland Clinic Neurological Institute is comprised of a multidisciplinary team of hundreds of physicians and surgeons who provide expert management of neurological, spine, and psychiatric conditions, serving locations across Northeast Ohio and around the world. We specialize in the entire spectrum of disorders, handling everything from the most common to the most complex, from back pain and brain tumors to multiple sclerosis and Alzheimer's disease and more. We are here tonight to answer your questions, share our expertise, and provide clinical insights on how to tell if your pain originates from your spine, simple ways to adjust your lifestyle to avoid back and neck aches, when to see a specialist, how to manage through physical therapy and medicine, and when medical procedures or surgeries may be appropriate. We've had more than 300 questions submitted for tonight's event, so we'll do our very best to answer as many as we can. We will also send out an email after the event that includes spine and neck related resources. Before we get to our questions, I'd like the panelists to take a few moments to introduce themselves. They will each share a bit about their backgrounds and answer the question, what's the one thing you do in your life to prevent back pain? To kick things off, again, I'm Dr. Russell D'Amico, spine medicine interventionalist at Cleveland Clinic, and I'm also serving as tonight's moderator. I've been practicing at Cleveland Clinic for the last 20 years. I see patients in the Twinsburg Family Health and Ambulatory Surgery Center in Twinsburg, Ohio on the east side. My specific area of expertise is physical medicine and rehabilitation. I'm also board certified in pain medicine. And I'd like to say that the one thing I like to do to focus and prevent back pain is aerobic conditioning. So whether you're walking or riding the bike or elliptical machine or you're a big runner, I think the more cardiovascularly fit you are, the less likely you are to have some pain. Moving on here, I'm going to introduce our resident neurosurgeon and surgical expertise here, Dr. Gregory Harlock, who's going to give you his introduction.
Hi guys, Greg Harlock. I'm a neurosurgeon, work predominantly down in Akron, and I've been here for about 2 years. I've been in practice for 10. I got recruited down for Canada, so please forgive my Canadian accent. One of the things that I'm known for is I've got a lot of expertise with trauma. So complex spine surgery is my day job, and I do trauma surgery by night. I'll tell you right now. So I'm at an age now where I'm starting to experience some back pain I didn't have when I was younger. And I would say the same thing as Dr. D'Amico, that I try and face that head on, and usually that means I need to spend a little bit more time at the gym, and that usually gets me over the hump and gets me feeling better. So look forward to the panel tonight.
Thank you. Also, let me introduce Tarin Holland, our resident pain management specialist.
Evening, I'm Tarin Holland. I've been in practice about 6 years now, 2 at the Cleveland Clinic. I am mainly at South Point Hospital. Also, I specialize in interventions catered to the neck and back. One thing that I try to do daily to prevent or reduce back pain is core stabilizing exercises. So a lot of ab workouts.
Great. And let me also introduce Dr. Hanan Shah.
Hi, everyone. My name is Hanan Shah. I have been practicing going on just about a year now. I did my fellowship here at Cleveland Clinic. Dr. D'Amico is actually my program director. I primarily practice in Middleburg Heights. It's a new family health center. And if you're familiar with the area, it used to be the old Kmart that they transformed into that. So that's where all my clinic is. I do my injections here at Lutheran Hospital on West 25th. So that's where I do all my procedures. I don't think I mentioned this, but I'm a spine medicine interventionalist. Obviously, I train with Dr. D'Amico. So I treat neck, thoracic, and low back pain as conservatively as we can. And then when patients don't get better, we send them to our colleagues in surgery sometimes. The one thing I do to help prevent back pain on a daily basis, I would say, is kind of reiterating what everybody else sort of said, is staying as active as possible, incorporating core strength, although I'm not always diligent about that. But I think just being mobile and staying active is something that helps with back pain prevention overall, and a good healthy diet, of course.
Well, thank you, experts. Let's get this kicked off here. Our first question. This is going to be directed for Dr. Sela. What is spinal stenosis and how does it affect the body? And as a follow-up, how do you typically manage it?
All right. So, spinal stenosis, whenever you hear the word stenosis, I think it's just easy to think about narrowing or a tight space. So if you hear stenosis, just think of tightness or narrowing. So I brought this model. I don't know if it'll help understand it better, but here's the lumbar spine, for example. And, in the center, we have this canal. This is the central canal where the bundle of nerves run. And so when that space is tight, that's what we refer to as stenosis. We also talk about stenosis when we're looking at the spaces on the side where the nerves exit to go down to our legs, or in the neck, for example, down to our arms. And when that space is narrow as well, that again is called stenosis, but it's just of a different area. So, stenosis means tightness, particularly around either the bundle of nerves or the nerves that exit the spine. And there's various ways to treat it. A lot of times in medicine, we try a stepwise approach. So we trial anti-inflammatories as long as there's no contraindication to doing so. Analgesics, so Tylenol is a very common one because overall it's pretty safe. Steroids, another anti-inflammatory, physical therapy, focusing on core stabilization, and you'll hear that a lot throughout this discussion tonight. And when those things fail, then we proceed to doing injections if appropriate, and specifically epidural steroid injections to target that tightness, that stenosis. And so you may ask yourself, well, what does that do? So it's basically putting a strong anti-inflammatory medicine in a space that's tight and likely irritated, causing your symptoms. And then when that fails, then we go up the stepwise approach to possibly referral to surgery if appropriate. So that's just kind of a general overview of the treatment, but there's a lot of little things in between that as well.
Great, thank you. And what I like to tell my patients with stenosis, there's really two options. You can either fix the problem, which is done through surgery, and I tell them it's like having a clogged pipe in your sink in your house, so you can call the plumber. In this case, it's an orthopedic spine surgeon or neurosurgeon. I said, or you can treat the symptoms. And I'd say that, like you described, a stepwise approach and starting with the least invasive and most conservative is what a lot of people are looking for. So even though they may come in with potentially a surgical problem, most people don't seem to be going through their regular day saying, hey, I'm looking for a surgeon to do surgery. They're just looking for some type of a relief. And that's why it's great to have a good varied panel here. Moving on here, Dr. Holland, what are bulging or herniated discs, and how do you typically manage that in your specialty?
Oh, bulging and herniated discs. Imagine just like how Dr. Salah had the overall diagram that she had held up, where you can see the bones, and in between each bone is a disc. On average, when we're born, it's full of water. Has a lot of shock absorbency. And as we age, we lose that ability to withstand shock and pressure. And then once it becomes very fibrous, kind of like our fibrous tissue, like our ears, basically, if we overload that area, like our spine, the disc can bulge, and it usually bulges backwards towards the posterior, the ligaments, in addition to our overall nerves. And it can cause a lot of pain in your low back, in addition to pain going down your legs. On average, just like it was stated earlier, it's definitely a stepwise fashion to where making sure you're staying mobile, getting you into physical therapy, the anti-inflammatories, if you're able to take anti-inflammatories and there's no contraindication, oral steroids, and then progressing on to nerve medications, and or coming in for a intervention like an epidural steroid injection. And if those are not as effective as we would like them to be, then simply transitioning to unclogging the pipe, I guess, pulling out that overall disc, and that would be considered surgery.
Great, thank you. And Dr. Harlock, tell us, what is sciatica and radiating pound down your leg, and where does it originate, and what can you do about it?
Yeah, great question. So I'm going to take a step back and talk more generally about something called radiculopathies. So when that stenosis we've all been talking about affects a nerve coming off the spinal cord, two things are needed to cause pain. One is pinching, but the other thing is inflammation. So when those two things happen together, they can cause pain in the distribution of that nerve. And depending on the nerve, it can go to a very different place in your arm or your leg. That's one of the reasons that we go to school for so long, is to try and very precisely tell, is that pain that you're having related to a nerve that's pinched, and where is that pinching happening? And if we did a surgery, would it help? The term sciatica, it's sort of a subset of radiculopathies. In the lower extremity, most of the nerves that go to the legs, not all of them, but most of them pass through the sciatic nerve. It's actually the largest nerve in your body. It's about as big around as your pinky finger is. And it's sort of used as a catch-all to refer to a lot of leg pain that results from this. So it's something that we sometimes are the last resort for. So as a neurosurgeon, I think that my first and foremost duty is to try and guide a patient through without surgery. Surgery is a last resort, although surgery is highly successful in many cases, very safe in most cases. Surgery does come with a higher risk of complications than the other treatments you've been hearing about. So we try very hard to avoid it, but in some cases we can improve symptoms in various different ways. We can either remove the affected disc, or there could be other strategies where we make a little bit more space for that nerve. And again, if we can reduce either the pinching or the inflammation, usually one of those two things will help with the symptoms.
And I think as additional comment on that, when you're talking about symptoms radiating, so some patients will say it hurts in my buttock. They'll say it's their hip. And so the hip may be actually in the groin, where your ball meets into the cup or socket with regard to your hip. And so some people say, oh, it's my sciatica. And you ask them where it is, and they describe a pain just in their buttock. And so the true sciatic symptom would follow right down the distribution of the sciatic nerve. So you say it's straight down the back of the leg to the bottom of the foot. And so I think particularly when we're talking about symptoms radiating beyond the knee, or symptoms that radiate beyond the elbow, for sure, then we're talking about a nerve pinching issue versus what may be a referred pain. Somebody who has arthritis in the hip or arthritis in the shoulder may have some proximal symptoms that would mimic what we're talking about here.
Well, I agree. The two can be very difficult to tease out. And of course, the trickiest thing in medicine, I find that most of our patients have some degree of both problems. So there's a lot of skill and judgment required in terms of deciding what really needs treatment and whether surgery might help.
And so we'll move on here. So Dr. Holland, what is the best imaging to figure out what's going on in my back? MRI, CT, X-ray?
It definitely depends on what your symptoms are and what precipitated, your overall pain. Say if you are well into your 70s, have a history of osteoporosis, and you have a fall, definitely starting off with an X-ray and progressing to a CT scan if necessary to see if you've had any type of fractures or breaks in your back. Say if you were trying to carry 8 bags of groceries and didn't pick them up very well and you strained your back and then you have pain shooting down your leg. Definitely progressing more to an MRI, just to see specifically to target more of the soft tissues in your back and seeing where the issue lies. But it definitely depends on what's going on and what precipitated your pain.
And Dr. Harlock, as follow-up on that, with regard to CAT scan versus MRI, are there certain things you look for on one or you can visualize better than the other as far as surgery?
Yeah, no, there's some really important differences between those different tests. So what I would say, I'm actually going to start by telling you about x-rays. So even though we think of x-rays as being old-fashioned, they actually still have a very important role in our management of patients. So the big thing that x-rays can tell me is actually the best test of the ligaments, to get someone to bend forward, bend back, and seeing if the bones move on x-ray. It actually in some ways gives me more information than what an MRI does. An MRI is the best test that we have in terms of looking at the soft tissues. It tends to show us the discs, the ligaments, the spinal cord, the best of any of the tests. But there still also is a big role for CAT scans. CAT scans really look the best of any of the modalities at the bone. They give us much more resolution than what an X-ray does. In fact, there's parts of the spine that are hard to see on X-ray. For instance, your shoulders often get in the way when we try and look at the lower part of the neck. So a CAT scan can show us other things as well. It can show us if a previous surgery has actually achieved the fusion that it was intended to. Sometimes there can be ossification or calcification of some of the ligaments, for instance, in the neck, that we would need to take into account if we were going to do a surgery there. So all of these different tests have an important role. And to be honest, most of my patients will get all 3 of those studies before we do a surgery.
Great. Thank you. And also, I think the X-ray is a good test to identify numbering. So there are some people who may have 5 lumbar vertebrae, which would be the majority. There's some people who may have 6 or 4. And so if you're going to plan some type of an intervention, whether an injection or a surgery, you want to make sure that you're getting it done at an intended or appropriate level. So, but yes, thank you, experts. Dr. Sela, when you say chronic back pain, what's the timeline that you follow? Is it when someone suffered daily for 3 months, 6 months, a year?
Yeah, so when we refer to chronic back pain, we're usually referring to pain that has persisted after some sort of inciting event. And sometimes there is no specific inciting event or trauma, but that's lingered on for around 3 months or more. It doesn't have to be a daily persistent pain, but it can be intermittent. But that general time frame of having that sort of pain is where we start to put it in the category of chronic pain. And then, beyond that, treatments vary for that, which we'll get into. But yeah, usually it's around that 3-month mark.
And I think that's important as far as the timeline. Some people would say chronic pain is thinking that it's years, when in actuality it's pains persisting beyond what you'd expect that a normal course would be. So when I trained back in the Stone Age, we would usually tell people that 50% of people with acute episodes of back or neck pain would be better in 2 weeks. Probably about 75% would be better in under 8 weeks. And you probably expected 95% to be better in under the 12-week period. And that's with conservative care. And so I think tincture of time in certain instances may be what you need, but I think a lot of what we're talking about today is being proactive and making sure we can identify appropriate care and diagnostic measures to get people as quickly better as we can. Dr. Holland's here. What is the most common etiology for non-traumatic localized mid-thoracic back pain? Is it facet arthritis? And what is kind of the most effective treatments for that area?
Definitely, as we all age, we naturally will collect some level of arthritis, especially in the small joints of our backs. And a lot of times for non-traumatic localized back pain, it's usually an accumulation of that overall arthritis, which is, collected in the facet joints. And then the pretty much most effective treatment for the pain, specifically, definitely going through that stepwise fashion, making sure that you're strengthening your core, going to physical therapy, covering the pain with overall anti-inflammatories such as NSAIDs, such as ibuprofen and Tylenol. There's no contraindication. And then specifically for those small facet joints in the low back, there is a procedure that can be done. We target the medial branches, initially starting off with blocking those nerves with lidocaine, or a different local anesthetic. And what that does, it turns those nerves off and see how much of your pain is reduced. And just like when you go to the dentist and they numb the back of your mouth and your face goes numb, same concept with placing any lidocaine or local anesthetic on the nerves in that area. And if that is, if you have a significant amount of pain relief, then it's progressing on to what we call a radio frequency ablation. What that is using specialty needles and warming up that area. And it pretty much, imagine a tunnel between Cleveland and Buffalo, and we collapse that tunnel. And overall, what the radio frequency does, it uses a specialty needle to turn or block the overall passageway between the nerve stimuli from the pain of the back to the brain. Naturally, within time, those nerves, just like any nerve, can grow back, but it does take about a number of months to about a year for the nerve to grow back.
And is that the type of procedure that could be repeated again in the future if the pain returns?
Definitely. So as the nerve grows back, the pain will resurface. And so we can repeat the overall radio frequency ablation portion of that procedure.
And I think in line with the radio frequency, this is the type of procedure that is part of the stepwise and starting with small non-invasive things, and you build up to that. And I think insurances now are requiring functional improvement. So it's no longer just, oh, my pain used to be an 8 and you block the nerve and it went down to a 0 for a period of time. We need to document that there is improvement, that the patients are able to do more. So were they able to go to the gym? Were they able to mow the lawn? Could they take care of the grandkids? Can they, bend up and down and do some yard work? And I think that's the key, is that during the initial diagnostic phase, you need to explain carefully that you want them to do activities that would typically cause them pain. And if it doesn't cause them pain, you're increasing the likelihood of a successful procedure. So I think that's part of a team, but it's not just a procedure to relieve people of their pain. You're trying to relieve the pain enough so that they can participate in life or participate in a good exercise program. And we'll keep going here. So this is a surgical one, I guess, of kind. So how do you typically treat kyphosis? And is surgery an option when you're elderly?
Very good. So kyphosis is a forward bend of the spine and can happen in different parts of the spine. So we commonly see it in the neck. For instance, surgeons, because we spend a lot of our day hunched over, operating surgeons quite commonly get it, but can happen for different reasons. So another very common cause would be trauma. Prior spine surgery can be a cause of it. One that my grandma had is osteoporosis. So many of us have probably seen people that have something called the dowager's hump, where the middle part of the spine behind the heart really can get a forward bend. And the reality is that all of these different causes of kyphosis can be approached a little bit differently. For instance, in the case of my grandma, I think the best treatment for her was treatment of her osteoporosis. And unfortunately, there's a lot of good new medications that weren't around when I was in medical school that are very effective at trying to prevent further spine fractures that are contributing to that kyphosis, for instance. the mainstay is always going to be physical therapy. I think that's going to be a very common theme throughout tonight. In some instances, we think maintaining good posture can help to prevent progression of a kyphosis. But if conservative management fails, we can consider surgery. The surgeries are different depending where in the spine they happen. The surgeries can be, from the front, from the back, or sometimes in both places. And some of these surgeries can be towards the bigger end of the surgeries that we do in the spine. For instance, there's a procedure called a pedicle subtraction osteotomy, which involves going down in the lower part of the spine behind your abdomen, and we actually can cut a wedge out of the bone, and we actually can realign the spine. So that's something that's a big surgery. Not every spine surgeon does them. And there's certainly some risk to doing the procedure, and we do lots of different things to reduce that risk. In terms of the issue of age, that's a very good question. So what I would say is there's no specific age cutoff. The older someone gets, the more closely we're going to scrutinize someone's candidacy for surgery and really question, are they going to benefit from this? Is it worth the risks of the surgery? As you get older, the issue of osteoporosis is actually very important for spine surgeons, because the way that we correct the scoliosis and the kyphosis is with screws and rods. So if you haven't got good bone quality that's going to hold those screws in, that's something that we really have to think hard about. And what I would say is that, deciding whether someone could have a surgery or should have a surgery, that's a very nuanced decision. It's very patient specific, but it's something that as a surgeon, we spend all day, every day working through that with different people. Ultimately, it's generally going to be the patient's decision if they're offered surgery, if it's something they wish to have.
And I think you bring up a good point. This is what we call shared decision making. So I think if you had a trauma and you had a broken bone and you're doing something potentially as a life-saving or limb salvaging procedure, that's different than if you have an acquired deformity and it's been happening over an extended period of time and there's risk involved with surgery. And so the idea is that you need to speak with your loved one and family members and have a good understanding of what the problem is, what the procedure is, and potentially what the recovery is. As you were alluding to, some of these are very extensive and major surgeries. So if it's an extensive recovery, are you set that you're going to be able to go home, or you're going to have a stay in a rehabilitation facility? Is it something where you're going to need pain medication? Or are you going to be able to get up and down the flights of steps if you live in a 5th floor walk up? I mean, it's a lot of moving parts and pieces that are involved. But as an aside or follow up to that, can you comment on Scheuermann's disease as well?
Yeah, so Scheuermann's disease is a subtype of kyphosis, and it's felt to be sort of a congenital or a condition that you're born with, where the front aspect, it's usually 5 contiguous vertebral bodies, where the front of the vertebral body didn't grow as high as the back part. So that can cause a forward tilt in the upper part of the thoracic spine behind the heart. We are getting better at managing that surgically. We've got some new techniques that involve some expandable cages and things of that nature. But actually, in most cases, in Scheuermann's kyphosis, we avoid surgery. So here again, conservative management with physical therapy is very effective. And again, I can tell you from my own life, the PT is very effective for the back pain that I have. Another thing that we do consider is bracing. Braces in spine are a bit of a double-edged sword. One of the problems with the brace is that it can take over the work of the muscles. So PT is all about building up the muscles and helping to, the muscles almost become like an internal brace. They help as shock absorbers. They take the stress off the spine. when we wear a brace too much, it starts to make those muscles weak. So we try and get people with Sherman's to wear the brace, a couple hours a day when they're going to do something that they know really is going to irritate their back. So it's pretty accepted that more than half of patients, and probably in fact 80% of patients with Sherman's will probably be managed successfully without surgery. But there are surgical options for people that are in that 20% that conservative management isn't sufficiently helping.
Great. And I think when we were talking about the x-rays earlier, I think with kyphosis or with scoliosis, certainly getting the full-length spine x-rays is probably something that is done very commonly. So again, good place to start with the x-ray, not always just going right out of the gate with MRI. So a lot of good information that way. Dr. Holland, can you tell me about how you would know if my back pain is arthritic, and what is the best medical management for arthritis in the back if I can't take NSAIDs?
So, like I'll reiterate what we had talked about earlier, like the arthritis, naturally we're all gonna just collect arthritis, especially in those small joints of our backs. And usually with the arthritic back pain, it is what we like to call axial. And so meaning just the low back, nothing radiating down your leg. And so with that, it is making sure, again, seeing what we can do, medically managing, usually with NSAIDs, but if they are contraindicated or if you're unable to take NSAIDs, it would be leaning more on the Tylenol, of course, making sure that there's no contraindication there also. Definitely physical therapy, and then just the stepwise fashion going towards the overall medial branch blocks, the radiofrequency ablations, and if there's any instability in that area, making sure that you see an overall surgeon.
And then here, this is another one for you. Will fixing neck pain help with back pain? And how can low back pain be related to the nerves in the neck?
So will fixing the neck pain help your back pain? It just depends on really what's going on. Say if you have a significant amount of spinal stenosis, especially in the neck area, any pretty much portion beyond that area around your spinal cord can naturally be affected because it's higher in the totem pole. And alleviating that pressure, say with the surgery, can help alleviate any pressure that's collecting at that area or at that level. And then can low back pain be related to the nerves in the neck? I have not come across that as of right now, but definitely, I'll definitely have to research more in regards to that. And if I do see a patient, definitely make sure I dive into it very well.
And I think this is a good point here. If people do have diffuse or widespread pain, there are non-spine etiologies. So could you comment on some other symptoms or diagnoses?
Definitely. So if you're having neck and back pain, full spine pain, kind of widespread pain, you definitely can have kind of what we like to call a kind of central sensitization, or especially if you're having widespread pain all over, potentially even having a syndrome similar to fibromyalgia. And usually with that, specifically with fibromyalgia, it is treated with low impact exercises. And there's 3 different FDA approved medications specifically for that. Specifically, Lyrica, Cymbalta, in addition to Savella. And then making sure that you are practicing really great sleep hygiene, exercising daily, managing your stress, and eating a very healthy diet.
Great, thank you. And then here, Dr. Saylor, this one's for you. This was also about exercise. So can you give us some examples of recommended exercises or things that you may recommend for different problems related to the back or neck?
Yeah, so different exercises, as we have touched on earlier, definitely focuses on core strength. And the reason is when you have a weak core, your spine is not as supported as it should be. Your posture can be altered because of that. And so one of the keys to physical therapy or any kind of exercise is focusing on the core. So that would be exercises targeting that. So crunches, planks, and not everybody can do that. I struggle with a plank myself. So, it's a work in progress, but doing these exercises a little bit at a time helps build that core, because we all have to start somewhere. And if you do that, enough, you may start to even feel the difference in the pressure offloaded in your spine with those core strengthening exercises. The other exercises you can do, and this is why we tend to send patients to a professional like a physical therapist to go through these exercises depending on the problem. But different, like when you pull the knee towards the chest, it can help alleviate your spine pain depending on what it's from, if it's muscular or if it's joint related. That stretch in and of itself can help offload that pressure temporarily. And then the other thing I was going to add is that depending on what you're going to the therapist for, whether it's back pain or you have some component of that sciatica pain in your leg, or you have a combination of both, we would cater your exercises accordingly. So if you're having a large degree of leg symptoms, although you may still have some back pain, we might have someone do some traction exercises, meaning stretching the spine to help alleviate those leg symptoms and open up those spaces where the nerves exit. Where if your main problem is pain localized to your low back, we may not necessarily incorporate traction unless for some reason that pressure offloading exercise does help you. And then you'll see things also that you can get at home, such as inversion tables, but I would not do that without the guidance of your physician, because you can have contraindications to doing such exercises. So there's a number of things, and you just have to speak to your spine doctor about what kind of exercise to do, and kind of combine that with the physical therapist for a nice home exercise plan.
And I like to tell the patients, they want to know what's the best exercise, and I say it's the one you're going to do. And so I think some people love aquatic therapy, and if you look great in a bathing suit and you don't mind being in a pool with other people, I think just sometimes water walking, other times floating in the deep end of the pool with a noodle is similar to the traction you're describing. I think certainly you can have a place in the water, but so many people like water therapy, but you really need to progress to a land-based program, and you really need to graduate to doing a program yourself. And so I think a lot of times the physical therapist will work on finding that directional preference. And so if it is related to a herniated disc, they may be able to find that lying on your belly and extending the back and centralize the symptoms and draw it out of the leg, focus it in the back, and then get rid of it. So the first session of therapy may be more following and repetitive testing to see whether or not you're actually getting better, not so much you just lying on a table where they put a hot pack on you and go talk to their girlfriend on the phone, and then put a stimulator on you and then go talk to a different girlfriend. I think this is something where I usually tell people that you're going to the therapist to kind of learn the things you need to do, and then go ahead and do it yourself. They can work on posture and body mechanics and eventually get them to the point where you're doing these exercises yourself. And so again, the core is very important. Flexibility is important. People with naturally tight hamstrings, it's a 2-joint muscle, so you may put an extra pull into your back. people who sit uninterrupted for periods of time. So if you're working at a computer and you're not getting up periodically and moving around, those are things that you can kind of recommend, not just for the therapy, but just regular. When you're looking at the computer, are your feet flat on the floor? Is your desk height appropriate with your computer monitor? You can get into ergonomic evaluations. And so there's a lot of things that you can do that are beyond the scope of what we've been talking about so far. Let's see here. We got some other good ones here. So Dr. Holrick here, how do you tell if the numbness and tingling in your legs is originating from the back and not the hip?
Yeah, no, so just the fact that it's numbness and tingling suggests that it's a nerve. So something like the hip joint can cause pain, but it shouldn't cause numbness. I'm going to be very suspicious if you come in with leg numbness that it could be related to a nerve issue in your back. Could be other things. A very common thing that an awful lot of our patients have is diabetes. So we always need to be very thoughtful in terms of what's the cause of it, because obviously a back surgery is not going to help diabetes. But if there's a nerve that's being pinched, that is something that we can help. And what we're going to be looking for is it's always more than one thing. So if there's a particular nerve that we think is causing the numbness, we're going to be looking to see is it also causing weakness that we would often see. The other big thing is, again, with the hip joint, there's some specific tests that we do when we examine someone that look at that joint. Simply moving someone's hip joint can often reproduce pain. There's another test called the Faber test, and I always tell patients it's sort of like doing some gymnastics right in the clinic room. So there's a lot that we do to try and tease that out. And again, the real tricky thing is when patients have more than one of these problems, because more often than not, they have some degree of more than one problem. And that requires a fair bit of experience and judgment to guide a patient through how best to tackle that.
And I think the gymnastics aside, it's very important to examine your patients. And so often when they're limping when they walk and they have pain in the groin and difficulty putting on their shoes and socks or difficulty getting in and out of the car, that may seem more in line with potentially a hip issue versus the numbness and tingling. And so you certainly can have issues with the nerves that supply the thigh. And so whether it's just supplying the skin in the lateral aspect, or whether or not it's coming from diabetes, or whether it's coming from a pinched nerve or stenosis in the back. And then as we do age, the likelihood of arthritis in the hip and the back does increase. And so is it one single problem or is it two overlapping problems? And I think that's where the clinical expertise, so seeing somebody who's an expert in their field that can look at you and perform an appropriate examination, look at appropriate imaging, and then if needed, I'll throw this out here, Dr. Holland, are there injections that you can do for people who have pain around the hip or pelvis?
Definitely. Specifically, if they are having hip pain and it is technically in the groin, we can target the overall hip joint, especially if it is arthritic. Specifically for the pelvis, there's other injections that target the overall nerves and conglomerate of nerves that we can access through the back to help those types of pain syndromes.
And then, Dr. Sela, can you just comment on bursitis?
Yeah, so in our body, we have bursa in different areas that kind of protect the bony prominences that we have, such as like on the top of the femur. So on the side of the hip joint itself, or your lateral side of the thigh, the upper portion, the femur has a bony prominence called a trochanter. There's a greater and a lesser trochanter, and on top of that is a bursa, which you can imagine kind of relate that to a like fluid-filled sac, if you will, that protects that bony prominence. So we have those, in our knees, on our elbows, and those can get inflamed at times. I would say the one that I see the most commonly inflamed in clinic is the trochanteric bursitis, so the one that causes that side of the hip pain. Usually, it's tender to the touch. It's hard to sleep on that side. Sometimes there's no inciting event. It just kind of started out of what seems to be nowhere, or, it was from walking 5 miles in a day. So sometimes there's no rhyme or reason as to why people develop the inflammation of the bursa or bursitis. But it's very treatable. Sometimes it's an injection either at the bedside in the clinic or under x-ray guidance. But again, it goes back to that stepwise approach where we would try anti-inflammatories, but also, seeing each patient is different. And so in some cases, it may be appropriate to jump to an injection. In other cases, it may be more appropriate to start with that most conservative stuff. So that's essentially what bursitis is.
Sure. And I think the key here is there's overlapping symptoms. So somebody says it hurts in their hip. Do they mean the outside of the hip? Do they mean the buttock, or do they mean the groin? And it may be a combination of each of these things. And there are people who have a bursitis, but also have some underlying arthritis or some underlying stenosis. And so I think the key is as we age, I tell people that the x-ray, the older we get, the more likely it is to have the arthritis and stenosis. And so if we took 100 people over the age of 70, they'd all have radiographic stenosis, but they may not have symptoms. And so the trick is we're treating people. We're not always just treating x-rays or MRIs. But as far as that goes, Dr. Holland, are there supplements or foods for arthritis or back and neck pain that seem to work or that you use in your practice?
Specifically for back and neck pain, for arthritis, definitely making sure that you're avoiding processed foods, trying to stick to more raw fruits, raw vegetables, and specifically for the overall supplements, many patients benefit from the anti-inflammatory supplements such as turmeric. And then I always encourage patients, especially if they have a sciatica pain or a radiculopathy, to make sure that they have some level of supplement for nerve health. So coenzyme Q10, alpha lipoic acid. And we all live in Cleveland. Well, most of us live in Cleveland, so we may be a little deprived of the sun, and making sure that we have some level of vitamin D supplementation.
Great, thank you. And then I'd say that, yes, we do need more sunshine here in Cleveland. So anybody can send sun our way, we appreciate that. And then I'd say that also calcium to go along with the vitamin D. So going back to some of the people that may have some osteoporosis, I think there are other fancier prescribed medications, some of which may be done by injection or infusion, and those are important when you're looking at surgical options. So I think sometimes somebody may be a candidate for surgical intervention, except for their bone health. And so I think having a good, solid, clearance ahead of time to make sure that they have good bone health, good cardiac status, they're breathing okay, they're getting their weight under control. Those are things that globally are good to diminish your need to see the doctor. And so I tell people to obviously avoid smoking. That's important. I tell everybody to try to maintain as close to their ideal body weight and to make sure that they do exercise. And so I think the supplements, whether turmeric or people come in with glucosamine, and there's questions. And I think, unfortunately, a lot of what we're recommending has been extrapolated from other areas of medicine. But I think, yes, if you eat your green leafy vegetables and you're working out, then you're probably putting yourself in the category of less likely to have pain. But I tell people that it's less likely, but it doesn't necessarily get to zero. But I think if you're fitter and stronger, the recovery and the more goal-oriented you are with the recovery, I think the better it is for people than just saying, oh, I hurt and I'm not able to do anything. The key is to focus on what they can do or what they're willing to do to try to get back to what they can. So let's see here. This is another surgical one. Seems like we've had a bunch of those, but we appreciate your expertise here. So what can I do if I still have pain and stiffness following a cervical or lumbar surgery, whether laminectomy or fusion? And when is it worth getting a second opinion about long-term management for these conditions?
Yeah, so the way that I counsel my patients is really after surgery, it takes a full 6 months to heal up. And it depends a little bit on exactly what we're talking about. For instance, the bone can take about 6 months to fuse if the goal of the surgery was to fuse the spine. If you're looking at trying to improve spinal cord function, that can take 12 to 18 months. So we really want to fully see how you recover from that first surgery before we start thinking about other ones and whether more needs to be done. But I think after that 6 month mark for most spine procedures, it's very reasonable to be looking at if screws were put in, are the screws appropriately positioned? Have they come loose? Sometimes another problem that we can see after surgery, there can be problems with instability, where all of a sudden bones will start to slide forward a little bit on each other, and that can be a cause of back pain and discomfort. So I would certainly be thinking, after about 6 months, whether it's time to look and see if more should be done.
Great, thank you. And I know I've been dishing out the question, so I guess there's one here with my name on it. So I'll try to answer it as best I can. What's the difference between how a DO would manage back pain versus a DC or chiropractor? And I guess osteopathic physicians during their training do learn manipulative techniques. So some of which may be high velocity, low amplitude, kind of the rack 'em and crack 'em that people associate with chiropractors, but some of them may be gentle, almost myofascial or stretching techniques or muscle energy. So I think hands-on, when the providers are good, whether osteopathic or chiropractic, I think that may be good for axial symptoms, so pain in the neck or the mid or low back. When we're talking about radicular or radiating pains that come from a pinched nerve, the fear is that if there's too much movement or racking and cracking here, that you could potentially further impinge or irritate that nerve and make symptoms worse. And so I think it depends on who you see as to what you get. And so I think I do send plenty of patients to both the chiropractors and osteopathic physicians that specialize in manipulation. So there's definitely a good base for that at the clinic. And whether you see them early and it's a myofascial technique or myofascial pain, or it's just general arthritic pain and stiffness where they're working on your range of motion, I think it's something where if it works, then they do several sessions and hopefully get you back out there. Dr. Wilson was my partner here for years, was excellent with his hands, and he would say, give me 5 times. He said, I'm going to make you all better, and we don't have to do it again. I'm going to make you no better, and we don't have to do it again, or you're partially better, where we consider whether or not to kind of continue on with that path. The other difference I'd say with the DOs versus the DCs is that the chiropractors, even though they may say chiropractic physician, they do manipulation and may work with some physical therapists and talk to you about your diet and exercise. But the osteopathic physicians actually are licensed to practice medicine and surgery. So maybe somebody who can perform surgery on you, somebody who can perform an injection if indicated, or somebody who can prescribe medication. So there's a little bit difference in terms of the schooling, but as far as the manipulation, I think that there is pretty good overlap there. And then this one here, since we're sticking with the surgery, and this may be our last question, and we'll maybe have some parting shots from each of our experts, but what determines whether to see an orthopedic surgeon or a neurosurgeon with regard to spine surgery?
That is one of my favorite questions. And again, except that I'm a neurosurgeon, so I think everyone knows that. What I would say is I think it used to make much more of a difference. And what happens to be a spine surgeon, so whether you're an orthopedic surgeon or a neurosurgeon, you train for 5 to 6 years in your core discipline. So orthopedic surgery is very much focused on the bone, bone fractures, bone healing, biology of bone. A neurosurgeon is very focused on the nerve elements, so brain, spinal cord, peripheral nerves. And so from that core training, we then go on to do at least a year of focus training on spine. And spine, there's been a debate about potentially spine becoming a totally separate subspecialty. It's become a very rich and complicated field. And whereas in the past it may have mattered, I think at this point you're going to get very similar care regardless of whether you have a neurosurgeon or an orthopedic surgeon. So where the difference is a little bit more apparent, I would say that orthopedic surgeons on average are more likely to be deformity surgeons, big, large instrumented constructs, things like that. Neurosurgeons are the people you need to see if you've got a tumor in your spinal cord, a tumor of your nerves. Orthopedic surgeons typically won't actually operate on the nerves specifically. The other thing that's very interesting is there's probably 5 orthopedic spine surgeons for every 1 neurosurgeon. So those are just a few little summaries of the ways that we're different, but for the most part these days we're the same.
Right. And I'd like to also throw in that I think some institutions seem to be dominant neurosurgery and very small orthopedics or vice versa. And I think the great part about working here at Cleveland at the clinic is that the neurosurgeons and orthopedic spine surgeons all get along very well. We do have shared education and conferences. So I think even having our medical spine fellows visit with the surgeons and understand surgical decision making, this is something where you don't just, oh, don't know what to do here, go see a surgeon. I mean, we have a good understanding because we're working with the surgeons and understand the type of patients that they like to see and what their expertise is. So if somebody has a deformity and somebody has that as a clinical interest or an area of research, we know who likes to do those big operations that may take 8 or 12 hours to do versus who may handle something different. And I think being at a large institution like this, people are experts in not only a broad array of things, but across multiple disciplines. And the fact that we're all in the Neurological Institute together, orthopedic surgeons, neurosurgeons, anesthesia pain specialists, rheumatologists, physical medicine, rehab specialists, whether interventionalists or not, I think we probably have the type of doctor that you would need to see. One last question here, I guess I'll throw out for Dr. Holland and Dr. Sela. What about acupuncture? Is that something that you have sent patients for? And do you have any comments about it?
I've sent patients for acupuncture. Acupuncture is definitely less of a Western medicine concept. It targets the overall meridians of your body and tries to release certain energies. And so the patients that have really benefited from it are usually patients that have musculoskeletal issues. But it can help. It definitely can help some patients.
Yeah, and to go off of that, I also send a lot of patients to acupuncture. Unfortunately, it seems like a lot of insurances don't necessarily cover it, or at least fully cover it, even partially cover it sometimes. But there are other treatments sort of similar to acupuncture, such as dry needling, which usually a physical therapist, if they're trained in that, can do that as well. And I think that acupuncture is safe enough where the potential benefit certainly outweighs the risk of that treatment. And I find that it's more successful with a lot of muscular, we call it myofascial pain in the back. So it's something I commonly prescribe to patients. And the sort of mechanism of how acupuncture helps is kind of similar to like a TENS unit, for example. So there's these alternative treatments or modalities, we can call them, that sort of the way they work is by activating a pathway that then inhibits the pain pathway. So you can think about it like if you jam your thumb and you put pressure on your thumb, you notice the pain diminishes because now you're activating these pressure receptors, and as a result, that inhibits the pain pathway. Acupuncture is sort of similar, where you're adding a stimulus that sort of there's this complex pathway that's inhibited as a result, and your pain might diminish overall. So definitely something I commonly use and worthwhile looking into if you experience back pain.
And I think it was important with everybody here tonight, knowing that we start from very basics of how to do things all the way through major surgery. And so at anywhere, I tell people it's a kind of a continuum of care. or it's like a carousel that spins around. I say, nothing, exercise, medications, injections, surgery, and then other things. So these are the options. So you can get on and get off at any point. So it may be early on and you have a foot drop or a progressive weakness where maybe surgery's done because that's indicated at that time, rather than going through therapy for months or trying injections. Whereas some people, if it's not coming from a catastrophic injury or tumor, basically this is something where we can start out and kind of build and do it in a stepwise fashion. But I appreciate everybody here. The final question on acupuncture for the evening will conclude the Ask the Experts event here. I want to thank everybody for spending so much time with us this evening. Before the end of this week, you will receive an email with the spine and neck pain related resources, as well as details on how you can make an appointment and a link to the recording of this event so you can review it again. I appreciate everybody. Thank you all and have a good night.